Okay, here we are in Chapter 2. We're talking about drug use as a social problem. Keep in mind, a lot of these kinds of things are subjective. So when you think about things in your own head about drugs, I want you to challenge your own beliefs in good and bad directions, both ways. Okay? So when we talk about problems with drugs, we talk about two categories of things. And that one is problems related to actually taking the drug, right? So risk of developing drug dependence, risk of overdose, so actually of that drug, taking the drug. The other thing would be problems related to behaviors, like deviant behaviors that occur that are related to taking specific drugs, okay? So arrests, fines, jail time, expenses associated with drug prevention, drug treatment, things like that. Many, many other things too, okay? So when we talk about U.S. drug laws, things have changed a lot. So we used to have a laissez-faire attitude in the 1800s, okay? You do want to know that for the exam, okay? So we had this laissez-faire attitude. The idea was, if it's not hurting other people, you know, whatever. Like, do stuff, use drugs, or don't use drugs. We'll assume that you'll be okay. Or you won't be okay, but it's not affecting other people, okay? However, legislature and restrictions started to come in. Why? A few things. Toxicity. Some of these things are dangerous chemicals. Some people just don't know about them. Dependence. Some of these things are habit-forming. And sometimes people don't know about those things. Crime. Sometimes drug users become more dangerous. Okay? All possibilities here. So, when we talk about toxicity, and we will talk about toxicity in these 4 different categories for each specific drug. We will talk about physiological versus behavioral, and we'll talk about acute, so right now, versus chronic, long-term toxicity. All right? So, for example, acute toxicity in a heroin overdose. This is physiological. So this is physiological, physical, biological, whatever word you want to use there. Physiological toxicity, acute would be in a heroin overdose. You stop breathing. So you're using it right now. Acute problems, you stop breathing. That is a problem. Okay? Chronic physiological toxicity would be something like for people that use alcohol, heart disease, people that lots of things. People that use tobacco, lung cancer, people who use alcohol, cirrhosis of the liver. Look at this liver. You don't want this liver, okay? These are things that happen with long-term or chronic use that are toxic, okay? Then we have behavioral toxicity. So again, acute in the moment, behavioral toxicity are things like smashing your car and killing yourself or somebody else because you've been driving while drinking, okay? Intoxication that dangerously impairs behavioral functioning. Acute toxicity for other drugs, maybe like walking off a balcony or something like that, okay? Chronic behavioral toxicity would be you really change your lifestyle because you insist on using these drugs. Maybe there are strains on interpersonal relationships or your ability to go to work and things like that. So chronic behavioral toxicity. So we have acute and chronic for both physiological and behavioral. All right. Now, we have this information. This is DAWN. This is the Drug Abuse Warning Network. Okay, let me kind of tell you about it. So it's a system of collecting data on drug-related emergency room visits and emergency room deaths, okay? And it's collected at some U.S. metropolitan hospitals. So it's not representative of the entire country, and it's metropolitan hospitals. So it's not representative of, let's say, rural areas, okay? It collects data on illicit drugs, so illegal drugs, and misuse of legal prescription drugs, and misuse of over-the-counter drugs, okay? When they collect this data, it's not, are you here because of a drug-related thing? It is, you are here and do you use drugs? Not did you die from drugs, but did you die and you use drugs, okay? So they're collecting data on who of the people who go to the ER or die in the ER have been using which drugs. Okay. So toxicity data, alcohol in combination with something else is number one of people who are visiting the ER. Deaths, prescription opioids that are being used, of people who are visiting the ER. Okay. These are just our top things. Okay, and again, it's not that this drug is causing the visit, but they are visiting and they've been using this drug. Okay. So, does Dawn tell us how dangerous a drug is? It's simply number of mentions in total ER visits and deaths. It does not tell us the relative danger of a drug. It does not tell us the cause of the ER visit or the cause of death. Okay. So, other toxicity issues, blood-borne diseases. So specific toxicities for people who inject drugs. And let me tell you, you can actually inject a lot more drugs than you kind of might have thought before. People can be creative. But for people who do inject drugs, they need to think about blood-borne diseases, not necessarily a problem due to the drug, but due to the injection method. So sharing needles, you're taking someone else's blood and whatever else is in that, and then using it to stick it in your blood. AIDS, HIV, hepatitis, things like that. There's a lot of syringe exchange programs or needle exchange programs. It's an example of a harm reduction method. We're not saying you can't use the drug. We're not saying you should use the drug. What we're saying is if you're going to use the drug, please use clean needles. And here are some. You can bring your dirty ones. We'll give you new ones. It reduces the spread of these diseases that cause societal difficulties as well as a lot of money. Okay. The problem with these programs is that they are funded by local governments. They work. They really lower the rates of infection. However, some people don't support them because they feel like they're telling people it's okay to use the drug. So while it works, it makes some people uncomfortable. Okay. Problematic drug use. Okay, so what's the definition of addiction? It's difficult to define. A lot of people talk about addiction in different ways. Okay, does it matter which drug we're talking about? Does it matter how much time is spent on the drug taking? Does it matter how much of the drug is ingested? You know, when do you go from recreational use to problematic use? What we call recreational use in college, if you did that out of college, it would be considered problematic, right? There's just a lot of things, like, you know, what people do around here on football days. If you did it on a non-football day, it would be a problem. Things like that. Okay, sometimes I have people that will come in. I do assessments for disability services sometimes, and I'll have people that come in that I'll ask them about different drug use, and they'll say, "Oh, no, I don't use that anymore." And I'm like, "Oh, not at all?" I'm like, "No, not at all." I'm like, "Well, when's the last time?" "Oh, the last time? Gosh, it's been like a week." Okay, so I don't use it at all, in my view, is not the same as I haven't used cocaine in a week. Okay, or some people will say, "Well, I don't use that at all anymore." Well, I only use it like a couple times a week, or things like that. Like, we have different definitions, so you have to really kind of ask people more and more. Or alcohol, like, "Oh, I I drink socially, like I barely drink at all anymore. Well, how much do you drink? Well, like if I'm cleaning the house just by myself, I'll have like, 6 beers or something like that. Okay, like not making a judgment, trying not to make a judgment. However, just clearly we have different ideas of what not really drinking at all means. Okay? Now, when we talk about substance dependence, we look at these 3 basic processes: tolerance, physical dependence, and psychological dependence. We'll talk more about these in the slides coming up. They can be defined, they can be studied, we can understand these terms. Okay? So, tolerance. Tolerance can be said in 2 different ways. And one is the diminished effect of the drug after repeated use. So meaning, as I continue to use this much of the drug, I don't get the same effect anymore. So let's say I first start drinking and I have, a beer and I feel pretty drunk. And then after a long time when I just have 1 beer, eventually I'll have 1 beer and I don't feel anything. That's tolerance. You can say it in the other way, and that is that you need more to gain the same desired effect. So as to where before I could have 1 beer, now I need 12 beers to feel the same effect that I used to. Okay, so you could say either that if you use the same amount, you don't get the same thing from it, or you can say you need more of the drug to get the same effect. Okay, your body is developing ways to compensate for that chemical imbalance caused by the drug. So your body likes homeostasis. Your body likes to feel balanced. And if you put a beer in your body every day, eventually it thinks 1 beer is normal, so it changes its normal. And so now you need 2 beers to feel different, and then more and more and more. Okay? This is how you end up with people that are drinking like handles of vodka each day and still functioning. Okay, that develops over time. Physical dependence. Physical dependence is defined by the occurrence of what we call a withdrawal syndrome. Okay, physical dependence, physiological dependence is another term. And we talk about withdrawal, and that would be if you're using alcohol every day and you all of a sudden stop, you feel like poo-poo. Okay? You have withdrawal symptoms. Okay? Now with some drugs, like smoking, if you stop all of a sudden, you'll have withdrawal symptoms that people don't like. Most drugs, your withdrawal symptoms, you don't like but you can handle. If somebody is using alcohol at a high level and they stop all of a sudden, they need to go to the hospital immediately. Withdrawal symptoms from someone who's been using alcohol at a high level for a while are very, very dangerous, including seizures, heart problems. I mean, very, very dangerous. Detox needs to be done in a hospital situation. We'll talk about that again later. Okay. Tolerance typically comes before physical dependence. Physical dependence means that the body has adapted to the presence of the drug. It thinks this is normal. And so when you take it away, it freaks out. Okay. Then we have psychological dependence. This is usually like there's high frequency use of the drug. People talk about craving for the drug. People tend to relapse after stopping use of the drug if there's psychological dependence. Okay? So people that quit smoking, withdrawal symptoms should be gone in about 10 days. People that quit smoking often relapse a month later, a year later, when some sort of stressful event happens. And that shows that there is psychological dependence. Okay? Behavioral psychology looks at this dependence as like drug taking is reinforced by consequences. That is, I like the effect of the drug. I like the way it makes me feel. I like the way that it makes me not have to feel the way I feel when I am sober. So I'm reinforced by consequences of taking the drugs. And we see this when we give drugs to, like, let's say, rat lab animals, okay? So they're given the choice of, like, pushing the lever and getting that drug. And then eventually they're given the choice of either, like, pushing the lever to get the drug or pushing the lever to get food. And they will choose some of these drugs of abuse continuously over food, over other things. That shows that there is this, some sort of psychological dependence on it, okay? All right. Changing views of dependence. So we had our early medical models before 1960. The idea was that true addiction involved physical dependence. And therefore, you just have to treat the withdrawal symptoms and everything will be fine. But we see that that's not quite right. People relapse even after you treat the withdrawal symptoms. If that was right, all these programs would work a lot better than they do, right? Okay. Then we have this positive reinforcement model, and that is that drugs can reinforce behavior even without physical dependence. Okay, psychological dependence, which is based on reinforcement, is increasingly viewed as the driving force behind repeated drug use. Okay. This is a picture of our DSM-4 TR, or text revision. Okay, now we're using the DSM-5, which is a purple book. I call all my books by the colors of them. The DSM-4 was maroon. This one, TR, is silver book, and then now I have my purple book. More fun for me that way. Okay. So anyway, this is the book that we have all our disorders in. Now, I mentioned this before, but the DSM-4 had two different categories of diagnosing for each disorder. You could diagnose as substance abuse or substance dependence. These are, you would diagnose one or the other. You would not diagnose both things. The idea is that you have substance abuse, and then on a higher level you have substance dependence. And the idea is that if you diagnose abuse, we're going to assume that they don't meet criteria for dependence. If you diagnose dependence, we're going to assume they meet criteria for abuse. Okay, two kind of different levels there. And that would be for each thing. So cocaine abuse, cocaine dependence, alcohol abuse, alcohol dependence. Now, I want you to know that. I want you to understand the difference between abuse and dependence as far as diagnosing. I want you to know that for the test, and I want you to know that for your life. As you're looking at different things, as you're reading research, people will continue to use these categories. Okay? And all the former research uses this. Having said that, in the new DSM-5, there aren't any separation of categories, and they just call everything substance use disorder. So we'll have cocaine use disorder, alcohol use disorder. Your exam will ask you about this, the DSM-4 TR stuff, because this is what your book covers, and I feel like that's what's fair. But I do want you just to know that the new DSM-5 doesn't do it this way. Okay, so let's look at abuse. To be diagnosed as substance abuse, we'd have a maladaptive pattern of substance use leading to clinically significant impairment or distress, as manifested by one or more of these criteria occurring at any time in the same 12-month period. Okay? Recurrent substance use resulting in failure to fulfill major role obligations at work, at school, or home. Recurrent substance use in situations where it's physically hazardous. Recurrent substance-related legal problems. Continued substance use despite having persistent or recurrent social or interpersonal problems caused by or exacerbated by the effects of the substance. Okay, so we have to have one or more of those 4 things within the same 12-month period to be diagnosed as substance abuse, whatever that substance is. Okay, now substance dependence would be a maladaptive pattern of substance use leading to clinically significant impairment or distress as manifested by 3 or more of the following within the same 12-month period. Okay, tolerance, we talked about what that is. Withdrawal, substance is often taken in larger amounts or over a period longer than intended. Persistent desire or unsuccessful efforts to cut down or to control substance use. A great deal of time is spent on obtaining the substance. Important social, occupational, recreational activities are given up or reduced because of the substance use. And/or substance use continues despite knowledge of having a persistent or recurrent problem that is exacerbated by the substance. Okay? Tolerance and withdrawal don't have to be present. If they are present, you're going to find another one of these, at least one. So it's at least 3 of these have to be there to be a diagnosis of substance dependence. Okay? All right. Is dependence caused by the substance? Some drugs are more likely than others to lead to dependence. Okay? Heroin, crack cocaine, for example, are more likely to lead to dependence. However, not just the drug, it's also the route of administration. So anything that hits you faster and goes away faster is more likely to cause you to develop dependence. Okay, so it's more addictive. Anything that you're using and how you're using it, again, I'm going to say this again, the faster it hits you and the faster it's out of your system, the more likely it is to be addictive. Because if you're feeling like you want something now and you take it and it fixes the problem right away, you're happy about that, right? You definitely want that. And then once it goes away, you don't want to feel bad again, so you take it again, and you take it again, and you take it again, and you take it again. Okay? As to where, if we think about this differently, if something hits you slowly, so you're like, I feel bad, I'm going to take this. It takes a while to make you feel a bit better, and it kind of lasts for a long time, and it slowly goes away, you're less likely to be like, I need it again right away, because you know it's just going to take a while again. So you're less likely to become addicted to that. You absolutely can become addicted to that, it's just less likely. Okay. Is dependence biological? Is it due to definable biochemical or physical reactions in the brain? A lot of studies investigating this say that they suggest physiological consequences. However, it's not necessarily the cause of dependence. Okay, there are correlations, but not necessarily causes. Okay. An addictive personality, what the heck is that? People are always like, well, I have an addictive personality. Okay. We don't know that a drug changes somebody's personality. There are just so many factors in here that affect personality. However, what we do know is this. People that tend to have that sensation seeking, like, I love roller coasters and maybe I'll just like go get my tongue pierced, why not? That personality is more likely, correlational, more likely to have early substance use and early substance abuse. Okay. Alrighty. Let's see. Is it a family disorder? So actually we do see substance use in families. All right. alcohol dependence often exists within the framework of dysfunction. So it may be that other people in the family use this particular drug and therefore it feels acceptable, or maybe it's that the family is dysfunctional and therefore substance use you kind of go to escape. And there could be that substance abuse is making it more dysfunctional. So there could be a lot of factors contributing here. You kind of should get the gist here is that there are correlations, but basically there are just so many factors that could be at play for all of these things. Now, is it a disease? The founders of AA call it a disease. Now, you can't take a blood test for it, right? So you can't, you don't either have it or don't have it as far as taking a blood test. But the idea of calling it a disease is that before this, people just thought of people who have substance issues as bad people, as they have a moral or character flaw. And that doesn't really seem fair. That doesn't seem right. For some people, it becomes almost not a choice. And in that way, it seems like a disease. However, in other ways, it's not the same as like a disease. You can take a blood test and say, yes, you have this. Okay. It's better to think of disease as more of an analogy for dependence. Okay. Now, really we look at this thing called the biopsychosocial perspective. Biological, psychological, social perspective. Biopsychosocial. I said there's a lot of things at play. This is our best perspective here. That is, dependence is probably related to dysfunctions of biology, of personality, and of social interactions, and a combination of all of these things, and slightly different for different people. Okay. Does drug use cause crime? Well, drug use may change somebody a bit, and therefore maybe they become more of a criminal. However, there's not a lot of evidence to say it changes their personality. Often there are people who had more antisocial behaviors in the first place that commit crimes, and then they use substances, or people who are using substances end up committing crimes, but maybe they would have anyway. People under the influence sometimes do commit crimes because they're not thinking as much. There is more violent behavior among people who are drinking alcohol than not. And then there's just the idea that using a drug is illegal. Okay, so more people who are arrested are using drugs, not necessarily because they're doing other illegal things while using drugs. Some of that is true, but also just simply the fact that drug use itself is a crime. Selling drugs is a crime. Buying drugs is a crime. Sometimes crimes are carried out to obtain money for drugs. So there's a lot of factors in here also. All right, why do we try to regulate drugs? There's some legitimate social purpose, right? We want to protect society from the dangers of some types of drug use. However, some laws, as we will discuss, are not developed from any type of rational or scientific plan. A lot of them are not realistic. A lot of them are not effective. Some of them are. Some of them are not. A lot of them, as we will discuss, came about due to just racist thoughts. Okay? Very specific drugs were made illegal at specific times based on dislike for particular culture, particular race. And we will talk about that for sure. And there's all that. So, you have already watched the marijuana videos, so you will see sort of regulation and how that's happening and how that has changed, and to see in what ways it works and in what ways it's not working, at least with that one particular drug. And then you can kind of think about other drugs and how it's working or not working with those. Okay. I think that's all I'm going to say about this chapter. I'll see you in the next chapter.